Thank you for those great presentations. We now have, and let's see, until about 4:50, I guess, for some discussion. So questions or comments from the panel? I'm sorry, from the workshop members. Bernard?
I got the best seat here. I thought it was the worst seat to begin with, but turns out to be Bernard Dreyer. This is for Michael. What about, you mentioned sort of in passing, connecting the pharmacy to medication, and something we've been interested in at NYU in just having some automatic connections to electronic prescription writing. But how do we get the pharmacy really integrate, the pharmacist and pharmacies integrated into helping the physician in that triangle that you showed?
It's a great question, and I think there's been a few studies actually that have talked about embedding a pharmacist into primary care practices, and that's just not really cost effective for most. But pharmacists are now being explored as a possible add-on with patient-centered medical homes, and I think everybody is trying to figure out if that could ever be a sustainable kind of model. And I do think that, and I can't speak specifically because I am aware of some, I'm aware of several activities that are in demonstrations that are going on nationally with some of the national pharmacy chains, in which they are very much aggressively exploring ways that they can leverage technology in a way that they can provide direct support to patients, like by linking and partnering and basically becoming kind of having partnerships with various community providers. But the reality is that most of these practices don't all have CVS patients or Walgreens patients or Safeway or Rite Aid or whatever. So you have this kind of blend. So they're looking to see what kind of service, though, if they can kind of find a way to get in. And I think they're looking at the medical homes as an avenue. And the big struggle is also, can you give permission to a pharmacist that doesn't actually reside within your practice, is not as an employee, have access to the EHR and being able to view this information? But to do services like comprehensive medication reviews, to be there to provide decision support, not just for the patient, but also for the physician. These are things that I think are very much on the mindset of industry, and that may be something that I would imagine is going to start to change quite a bit, especially when they start seeing that there's ways that they can find reimbursement for doing like medication therapy management, not just among 65 and older and those with really complex chronic conditions, but that there's kind of a game plan for them that could like affect script lift or other things that they care about. So.
Thanks. Those were 3 fantastic presentations. I really enjoyed them. This question is for Brian. And I guess the first question is 14% cardiovascular risk high?
So I know that I am not a clinician, and I wouldn't dream to know the answer to that. And that's kind of the point. I don't know whether it's high or not.
Why would you trust me if I said it was high?
So this then gets to the point
I am a clinician.
of what the purpose is.
Right.
Right. And we've talked about this already to some degree in the context of informing versus persuading. Right. I cannot judge whether, as a clinician, you would look at that number and say, this person ought to be taking a particular set of actions. And I'm willing to shape the presentation in order to encourage that person to take those actions. If those actions are, hey, we ought to talk about this, that's not necessarily an intervention, but it is an attention signal. And if our interest in that number is not for him to take that action, then I go back to my original question, which is, well, then what is our purpose? Why is this cardiovascular risk calculator of value to this person? And I don't have a clear answer to that, so I tend to fall to the former, which is that it's a signal to action, in which case I want the output of that calculator to give this person a clear signal, which the 14% doesn't do.
Right. And I agree with you there. And I mean, and I'm not being critical of your presentation at all, because I think you raised all the right points, but I wanted to emphasize something that I wasn't sure that you addressed enough, is that we're putting a value when we say we want someone to take action because we think it's high. And what I think 14% is high personally, but George might not. He's a clinician also, used to be. Now he's retired. And we face that every day, day in and day out. Paul was talking earlier about chemotherapy, and is 3% high on a recurrence rate for cancer. And one of the biggest challenges I find is how do we help elicit the patient's values so that we can understand what's high for them? And that's a dance that, you know, we use all kinds of information. A lot of us will trust what the guidelines say. So the guidelines say if you're over 10%, it's high. So we have a risk calculator that I use in clinic every week that all of a sudden your risk turns red when you're over 10. And that raises patients' eyebrows a lot, and they're ready to act. It's very persuasive. If they're at 9, they're in the yellow zone and they don't really know what to do. There's really no difference between 9 and 10. But those are external cues that are based on some panel sitting in a room at the IOM saying that 10% is high, not based on that patient's underlying values. So how do we use these numbers and conversation to elicit values and make sense for the individual?
So let me just say, I think there are two different points that you're bringing up here. One is the point fundamentally that anytime we create a categorization of an underlying data, we're imposing some degree of value judgment of at what point you should be acting, what differences are meaningful, what thresholds are meaningful, et cetera. I don't deny that that's value laden and that there's all kinds of ethical questions that arise in the question of who gets to set those points. I also, however, want to remind us that not providing that is also an ethical choice. It's an ethical choice to leave the recipient of that number floating in the winds with no knowledge of how to interpret that number. And so we unfortunately are stuck between a rock and a hard place in that neither of the options are, in some sense, perfect. And then you get to this question of patient values. But I think the question here becomes, what is the signal that we're giving? If we say your test result is high, there's an implicit in colloquial English use of a signal to act. If we reframe that as this value is at a level you should talk to your doctor about, perhaps that signal to act is different in a qualitative way. I won't claim to know what the right types of evaluative labels are for all the different types of purposes, but I don't think that all labels are equivalent, that there are different ways in which we can group or categorize information for certain circumstances that will be most directly connected to the task that we want somebody to do. If what I want you to do is to call your doctor, then that's what the signal should be, not high. And that's the challenge here. I don't know. But you talk about breaking down the task. What is the task we're asking people to do? Are we asking them to have this self-concept of I'm a person with high risk? Or are we asking them to use this information as a signal to say, no, I don't need to act, or I do need to act? And then we have to make conscious choices about that.
So, Robert, I had a couple questions. I wanted to know how, it sounds like you've been at this for a while. And so I'm very curious to tap into some wisdom here from your years of experience doing this. So I had a couple sort of specific questions. One related to how you solicit feedback and ongoing sort of formative changes within the process. And if you could share with us, specific to sort of the health domain, what are the biggest lessons learned from doing this and being involved with trying to take information about health plans and health choices and make them as useful as they can be to people who are trying to get that information.
Well, I think one of the biggest lessons is the one that I was sort of hitting over the head throughout all that is that we need to simplify the cost comparison. And we're certainly, we learned that people care a whole lot about the cost comparison and that it's baffling for them. We need to find a way to simplify it. Beyond that, how do we monitor or how do we learn from what happens? We do some user testing where we will actually sit with people while they use the tool. And record what they do and then talk with them about it afterwards. We actually watch the use of the tool in the sense that we can see how many people actually clicked to that quality personalization option, and then we can actually see which sliders they pulled. And one of the interesting things on that front is that different people pull very different sliders, although there are some that are on average, that get more up pulls than others. The disease ones tend to be quite variable. They're either down or up, but so the average is not so high. But people pull the slider, for instance, on availability and quality of doctors. That gets pulled higher on average. The average pull for that is higher. And kind of interestingly, there was one of those topics on there. And we also know that we keep playing with the language, but haven't played enough with the language that we're not even describing those things anywhere near as well as we could be describing them, I'm sure, and haven't done enough user testing of that particular language of each of those categories. I'm focusing really on the quality thing here now. But among those things, health plan gives you in choosing the right test or treatment or whatever it was. It's the shared decision-making tab. That actually gets pulled down to my surprise. Even though plans can play a role in that, but people may think that the doctor plays a role in that, or they may not be, some people don't want anybody to engage them in shared decision-making. They just want somebody to tell them what to do. But even among people who do care about that, they may be pulling it down because they're not expecting that out of their plan. Also, care coordination, I think it's surprising to me they pulled down because, here these are things we really want plans to do, to play a big role in and to really be motivated, and they don't seem to attribute much role to plan in those things. A lot of this tells us something about what maybe we could do more in educating people, even in the context of this tool, to sort of say why this is important. But, we're doing this in very scarce time. So it may be that other people have to educate them on this in some other way, because once they're on that tool, they don't want to be there very long. So is that? We can talk about a lot of topics here, but okay. Oh, and they really want to know if they have a doctor. They really want to know, or have several doctors. They really want to know if that doctor's in the plan.
So just to highlight, what I heard you say was the cost conversation is at the top of a need.
Yeah, I think making this cost thing simple. We're actually doing the actuarial cost estimates for 2 states for their state exchanges. But I must say I've been kind of shocked by how little interest the IT contractors have had in this problem. They're very focused on eligibility. Maybe I'm not shocked because they got a lot to do. They're focused on eligibility and enrollment and things like that. But the lack of real focus up to this point on actually making this comparison tool work has been kind of disappointing to us. Very disappointing to us.
We have 5 tents up right now, and we'll cut off the questions after those 5. So we can move on. Cindy?
Thanks. I'm going to go back to Darren and Brian's point. And this was actually something that Darren and I struggled with when we were doing the Health Literacy Universal Cautions Toolkit. And one of the things that we wanted to include in the tool for creating effective written communication was a sample test result or lab result form. And we struggled with, well, how would we explain it so it was really clear? And what we ended up using was something that said, your cholesterol is high, come in and talk to the clinician. And I knew if I got that letter, I'd be really annoyed because it wouldn't have given me enough information, but it was sort of where we wound up in terms of a single communication that would be clear and actionable to everyone. But as we're talking about this, I think one of the things that strikes me is the need for training clinicians in communication and shared decision making, because a lot of what I hear is a power struggle. Maybe that's just me, but the doctor is deciding, you're too high, you're, not enough this, whatever, you need to do something. And, I had an exchange a couple years ago with my physician who said, you're too old to keep taking this medicine, it's too high a risk. And I was like, wait a second, I wasn't too old 6 months ago or a year ago. I don't think at this, 50, my risk was skyrocketed. No, that was, she had some rubric and this was, she wasn't going to prescribe it anymore. And so we can talk about putting meaning behind the, number or the risk, but also need to talk about that conversation and the thing that came up earlier today about eliciting preferences and, the Angelina Jolie example and things like that, of we do have personal trade-offs to make. So if we just rely on the easy, too high, too low, that's somebody else's judgment being imposed.
So we're going to come back to this issue of how do we simplify yet reflect complexity ad nauseum, because it's inherent in the problem that we face. This story about absolutes, I think, resonates with me. My family's example is my wife's frustration with being slapped with the advanced maternal age label when her due date was 6 days past her 35th birthday. And she was not happy about that. But the point I'm trying to make is ultimately one that says the problem that needed to be talked about between you and your doctor was one in which there was no clear, simple answer, right? There were potential risks and there were potential benefits of continuing to take that medication. The signal that needed to be there was a signal to have the conversation, not a signal to say, this is the answer. If we can create communications that have the goal of raising that conversation, perhaps we can then allow those conversations to then take place. The example I've been working on in my own work has been thinking about the context of discontinuation of cancer screening. How do we engage patients with the question of at what point is a colonoscopy or a mammography actually not beneficial? Tough problem. But I wouldn't want to define an absolute threshold and think that it applies to everybody. I wouldn't even necessarily think it would apply to me from one moment to the next. I would like to come to some way of flagging at what point is that conversation appropriate. And maybe we can think about that as the task that needs to be done in the communication as opposed to an answer to the problem.
Wilma?
Wilma Alvarado Little. So I really enjoyed the presentations. Thank you very much. But I have a question because as I was listening to this, I was thinking, it's no secret that healthcare English to English can be more interesting than we care for it to be. And so my question is, for example, Mr. Krughoff, with the tool you have there been accommodations for, say, for example, our visually impaired population or for our disabled communities with any of the research or best practices, if you will, when working with communities that, for example, or individuals who may have some challenges that are already putting their healthcare situation a bit more complicated than, say, for example, myself, and again, depending, when you're not feeling well or you're not 100% or a loved one is not 100%, you're a different person. And so my question then is to those who have other challenges in addition to those that we might experience. Has there been a discussion to accommodate or include or partner to look at possible next steps as well?
Not enough. Well, first of all, I'd say that our tool is only in English. It is 508 compliant, but that doesn't tell you too much. We've basically supported it on its own, though. It's not to say that a state couldn't just say we're going to do this, or that the feds couldn't say they're going to do this, and they have a whole lot more money than we have to do it. And I hope they will, and we would be happy to work with them on that in any way we can.
Okay, I can't tell who's oh, go ahead.
Hi, it's Kim Parson with the Humana Consumer Experience Center of Excellence. And again, regarding the tool, you said that it was used, how long has the tool been in use?
In one form or another for 34 years. In the first 22 of those years, it was in book form, and we sold a lot of books to federal employees one at a time, or federal retirees one at a time, and that's what supported it. For the last 12 years or so, it's been online, and a lot of agencies actually subscribe to it now for their employees. So HHS subscribes to it for their employees. So it's been going on for a long time.
I just wanted to make sure that my next question was relevant then, because we're going to see more and more of that, right? So I'm just wondering about the satisfaction data that you've seen on the other end in terms of people's plan choices that the tool led them to. Specifically, you mentioned that the majority of people that you see make their plan choices based on that first screen, right, without going into that personalization. I just wonder what insights that you've seen from that.
Well, if you're asking me, do they say, "Oh, this was wonderful"? They do, and they thank us for it because they were very confused with other things. Whether we try to look at our judgment of whether they've made an appropriate choice. Okay, so we will either survey them to ask them what they did, what they had before, and what they have now, and then we think that that they've made an appropriate choice. Our appropriate choice question is often very heavily weighted toward cost. Okay, so did they at least is the plan they chose the one that actually one of several that is a better deal for them than what they had before from a cost standpoint. But they may have wholly different criteria for making a choice, and so even if we think they made the wrong choice, it may not be wrong for them. And we always ask them, what was the basis for your choice, so we can sort of look at is the choice they made consistent with what they said they cared about. But I don't want to. I would be going way overboard if I made it sound like this is great science we're doing here. I mean, it's trying to get feedback, trying to learn something from it, and I do think it's working for people, but and I do think it's working much better than the alternative, which is nothing.
Linda?
I want to thank you all for a wonderful afternoon. This has been just the kind of suggestions about what we can do that we've been really yearning for. So thank you very much. I just have one quick question for you, Robert, about the checkbook. Are you going to be doing this for the marketplaces, the exchanges?
A couple things. One thing is we actually wrote a paper a year and a half ago and sort of circulated to anybody who was interested in it as to what we think should be done. It's 15-page paper or whatever that sort of describes what we think the future should be and the reasons for them. We've hoped that there would be uptake in that. the most positive one was the state of Illinois, actually put it in its RFP to its IT contractors and said, we want to have this among all the other eligibility stuff. Then Illinois, of course, then decided not to have an exchange. But there has been, pickup of these ideas in various forms. I think gradually more and more. I just think people have been preoccupied with the mechanics of these exchanges. We will just keep trying to persuade people to, to think about those first things that I had up on the screen, the things that ought to be in a tool and that are not hard to put in a tool, and let's get them in those tools. From our standpoint, we would actually like to do it within a couple of exchanges, actually do the whole thing. What we're doing now is, as I say, we're doing the actuarial cost estimate for a couple of exchanges, which is a nice thing, but then it's not in the whole context, and I must say context makes a big difference. Actually, Lynn has a paper on choice architecture, and it's a big deal where this information shows up. So we'd like to do it in a couple of things where we actually did the whole thing, and maybe that will come eventually, but it's not going to happen before October 1st, to our disappointment. By being in it, then you can also see, you're on the inside and you can see what else other people could do to make it better. I mean, for instance, just sitting there, we're actually doing the provider directory for one state, too, the all-plan provider directory. And you sit there and then you say, well, we really ought to be pulling stuff from HHS's Physician Compare website as one of the things in here. And then you say, but what's there? And can we even get access to that information and stuff? So when you're on the inside, as a consumer organization, you're on the inside of a few of these things. You at least know what signals to send back out, and you have some standing to say, hey, other players in this could make it better.
And one other sort of a comment, Brian, I'd like to be provocative right back to you. I think not only is the answer no about the number, my suggestion is that if we could really have conversations about this, that the numbers would matter far less to patients' sense of confidence that they'd made the right decision. Because the conversation, the relationship with a trusted, reliable person over time is probably going to make a bigger difference in whether people feel like they've made a good decision or not, more so than any precise number or even somebody's interpretation of that number.
So I will both agree and disagree. I totally agree in the value and importance of that relationship, but I'm also aware that I am more trusting of a categorization, a recommendation, if I know that there is data that exists behind it, and I have the opportunity, if I wish to have that explained to me to understand why that supports the recommendation. And this tiered structure, I think, represents that. It doesn't mean I have to have the data be hit with the data right up front, but it sometimes does mean that I want to have that access to say, well, why are you saying this is less risky? Oh, okay, that really is a big difference between those numbers. Now I'm willing to say, okay, I understand.
So the missing, to me, as a interpersonal communication person, I have to self-disclose, is what kind of conversations? What should be the design of those conversations to make this work? And that's been missing today.
If I can just agree with you with the following statement. Just because we have information doesn't mean that that's the best way to inform somebody. And that is precisely your point about designing the communication. What does need to be communicated at a level of information? And maybe that's data sometimes, and maybe it's not.
Sorry. Thank you again for this wonderful presentation. Yeah, right.